Hello everybody, I'm going to give you a brief introduction on lung transplant. As you might know, lung transplants are performed in 3 centers in the Netherlands. Of course here at the Erasmus MC, but also in the north of the Netherlands in the UMCG and in Utrecht in the UMC-U. We have been performing lung transplants in Rotterdam since 2001. The indication for a lung transplant is a severe, progressive, end-stage lung disease with limited life expectancy. As a rule of thumb, someone has to have a life expectancy of less than 2 years before there's an indication for a lung transplant. The underlying lung disease has to be non-reversible and has been treated to the maximum extent before someone is a candidate for a lung transplant. The most common diseases we treat with a lung transplant are COPD or emphysema, as you can see here on the CT scan, where the lung parenchyma is destroyed. Mostly that's due to smoking. Or interstitial lung disease, also known as lung fibrosis, as you can see here on the CT scan. Pulmonary hypertension, which is more of a vascular disease than a disease of the lung parenchyma itself. And there's the infectious lung diseases like cystic fibrosis or bronchiectasis. An example is shown here on the CT scan. We also do transplants, but that's only limited to 1 or 2 per year here at Erasmus MC. This is the ratio of the transplants we've been doing the last couple of years. And as you can see, it's about 50-50 between COPD and lung fibrosis. That's mainly due to the fact that the Erasmus MC is a lung fibrosis center, so we get a lot of referrals for lung fibrosis. You can also see that the amount of transplants for cystic fibrosis has been declining over the past year. That's due to the fact that there's better medication for cystic fibrosis on the market nowadays. If you look at the numbers for lung transplant nationwide, the numbers are rising. As you can see here on the top, last year we did 122 lung transplants in the Netherlands. But you can also see at the right bottom side that the age of the patients that are transplanted are rising as well. So we have to deal with more comorbidities after lung transplant. In this figure you can see our program is growing. I think we've been about doubled since 2017, and also last year and this year our numbers are increasing even more. To assess if a lung transplant is possible, we do a screening. We admit patients to the hospital for 5 years and do excessive evaluation to see if a lung transplant is possible. We do lab test, laboratory test, microbiology test, but we also do radiology, we do cardiac assessment, and the physician, the dietitian, and the social worker are involved in our screening program. At the end of the assessment, we select patients who are qualified for lung transplant. Contraindications are various. There's a few obvious contraindications, like active smoking, and also an important contraindication is age. If someone is above 70 years of age, we don't do lung transplant anymore. Our waiting list is based on the lung allocation score, also known as the LAS score. And it has been developed to decrease waiting list mortality. And basically it comes down to the fact that more sick people are higher on the list, but it also takes into account on the possibility that someone after lung transplant has a longer survival. Furtherwise, we allocate on blood group and on total lung capacity. You can't give a too large organ to a small recipient or the other way around. There's various operation techniques for a lung transplant. The one we do most in the Erasmus MC is the anterolateral thoracotomy. As you can see on the right, we usually do bilateral lung transplants, so patients get 2 incisions. Sometimes, mainly due to anatomic variations, we do a clamp cell incision, and you can see on the left. And then this is the result. The old lung on the right is removed, and the new healthy lung is placed back in the thorax. Complications after lung transplant are various. In the beginning, we mostly see infections or rejection, and later in the trajectory, we mostly see toxicity of our medication or CLAD, which is stands for chronic lung allograft dysfunction or chronic rejection. For lung transplant, we have to give relatively high amount of immune suppression because of the high amount of rejection we see after lung transplant. So we also see a lot of toxicity due to our immune suppression. So it's always finding the balance between those. Our survival after transplant is about 10 years median. And if you compare that to international standards, it's quite good. That's mainly due to the fact that we see patients after lung transplant only here and don't do any shared care. So any complications are detected soon in the trajectory, so we can treat it properly. Thank you for your attention. Don't hesitate to get in contact if you have any questions, and good luck in the Erasmus MC.